Dr. Sriniwas, you please share your screen?
Yes. Okay.
Right.
Thank you, Dinesh, viewers, sir, Lalit, Dr. Jaiswal, my good friend Dr. Maniyar, and all others. मजा आ रहा है आप लोग से और एक बार बातचीत करने में, and that too a topic which is somewhat close to my heart. Persons who have helped me in making this slide is Dr. Nitya, who was an assistant professor at PSG, and also Dr. Satish Pai, who was professor at Manipal. We two together have been colleagues. He was my student and then became my colleague, and we did a lot of work together, and we share our slides with each other freely, and he has done this time also. Today we'll talk on photodermatosis, and this is a sort of skin condition which will occur on exposure to sunlight. The major group which we'll be discussing today is the idiopathic. Idiopathic means हम कारण नहीं जानते हैं, we don't know the cause. And then of course there are because of photosensitivity, because of chemical. Not that we know the cause, we know the etiology, but the pathomechanism is still not very clear. And then there are other photodermatitis like DNA, repair deficiencies, nutritional, metabolic, and then a group of conditions known as photoaggravated. That is, almost all skin conditions, when a person goes out in the sunlight, it can become more, and that is photoaggravation. Here, neither phototoxicity nor photoallergy plays a role. For example, acne, it will become more, that is photoaggravation. Any talk on phototherapy will have this electromagnetic spectrum. Of interest to us is the ultraviolet B and ultraviolet A. When the light comes through, the ultraviolet C is cut off by the ozone layer. Most of ultraviolet B, only 5% of the total dose that reaches is just 5% ultraviolet B. Rest all is ultraviolet A. A small amount of ultraviolet B and a large amount of ultraviolet A reaches along with the visual light and the infrared rays. So this is the spectrum. UVC cut here, it doesn't reach. UVB 5%, UVA most of it. This amount of light, ultraviolet light, that reaches the earth is affected by many factors. By latitude, by altitude. The closer or the higher you go up, you are exposed to more amount of ultraviolet light. That is not because when you're going closer to the skin, going up to Ooty or even the Himalayas doesn't take you much closer to the skin. But what it does is, it effectively reduces the stratosphere or the ozone layer. And because there is less amount of ozone above you, more amount of ultraviolet light reaches. We know that summer is hotter, so ultraviolet light also will be more during summer and less during winters. That is a seasonal variation. And we know that the days become bright and as the day progresses. So time of the day, in the mid-afternoon, we get more light, more ultraviolet light also. And then there are factors such as reflection, which could be from sand at places like Rajasthan and other places, or from water. So this is the image. Ultraviolet B packs a lot of energy. Mostly it is absorbed in the epidermis, not that it cannot penetrate, but all the chromophores for ultraviolet B is predominantly there in the epidermis, and so it gets absorbed over there, and its activity is predominantly in the epidermis, and malignancies and all mostly occurs because of ultraviolet B. Ultraviolet A has got a longer stride. It can penetrate better through the ozone layer. That is why 95% of it is ultraviolet A. It can also go deeper into the skin. So most of the pigmentary changes and the most of the aging changes, which is because of collagen and elastic fibers, occurs because of ultraviolet A. So this is the rays which I told you all about. And this is what happens. Sunlight comes down. It is absorbed. Then there are photobiological processes initiated. And then the visible changes occur on the skin. Photosensitivity is not properly understood. As I told you, why it occurs. The pathomechanism is still, there is a lot of gray areas. So in other words, there is a dark area in this photosensitivity. but it presents predominantly like a sunburn. However, in the Indian skin, the sunburn may not always be apparent. We may miss the erythema. So in the Indian skin, it can also present like pigmentation. There has been an erythema which was subclinical, which was not to be seen by the eye or was not noticed, but that goes off and gets replaced by pigmentation. So in India, it can present as pigmentation. So these are the photosensitive disorders which we'll be discussing, like PLE, chronic actinic dermatitis, actinic prurigo, etc. And then there are many photosensitizers. Photosensitizers can be topical, can be systemic. Topical photosensitizers are often the sunscreen. The sunscreen which is meant to absorb light can also cause sensitivity and cause the sensitization and can cause the dermatitis. Which are the sites which are going to get affected? It will differ from individual to individual, but the common sites which get exposed are the ones which gets affected, like the forehead, face, nose, cheeks, upper end of the sternomastoid, the V area of the chest. The rim of the pinna is very, very important, especially in the women. It gets covered. In the men or people who have got ears sticking out, it can be more. And as we age, the amount of protection we have on the scalp reduces, and hence head scalp also can develop the dermatitis. I'll show you in a pictorial way as to which are the sites which are affected. You can see the same sites which I told. In the hand, the dorso of the hand, the forearms. But then, as I said, each individual might have different occupation, different habits, and that is going to determine. If you are a person who drives for long distance, the right side of the face, the right forearm will be affected. The left side might be relatively spared. And for the person who does backseat driving, sitting on the rear, for them, the other side, the left side, may be affected. Another site which is commonly affected but not really noticed in case of photodermatitis is the dorso of the feet. People tend to stick their legs out, and so sunlight falls over there. And for those who wear bikinis and minis and all, thigh, and nowadays men also wear shorts and go out along, so the thigh also can get affected by the photodermatosis. So when it affects certain area is not affected. These are the areas where sunlight cannot reach, that is around the eyes, under the chin, behind the ear. These are the areas which are affected by airborne contact dermatitis because the dust can settle over there and can cause the dermatitis. Now, what are the skin lesions we get? We can get redness, we can get prurigo, we can get dermatitis, scaling, crusting, urticaria, all things, all these sort of changes. Some are immediate changes, some are late, and photosensitivity can also cause photoonycholysis. This is the one because of UVA, this lovely lady. She has got a hair and a lovely earring, which has been protecting one side of the face. So the proximal part of the face retains its youth, and UVA has done its, played its game in the front part of the face. This photograph was possibly by Dr. Arun Inamdar. So these are the conditions. The idiopathic means we do not know the cause. Of that, most important is the polymorphic light eruptions. And others are the variations of that to some extent, like hydrovaccine infamy, actinic prurigo, solar urticaria, chronic actinic dermatitis. Juvenile spring eruption is possibly a variation of actinic prurigo, so I won't be discussing. Some people give importance to that, some people don't. Photoallergic and phototoxic dermatitis is because of secondary to exogenous substance. Then metabolic conditions and genetic conditions are the xeroderma pigmentosum, cocaine, bloom, Rothman, porphyrias, pellagra, adnap. And photoaggravated are the parthenium, lupus, lichen planus actinicus, are the various conditions which are photoaggravated. So these are the conditions which we will be discussing today. I already named them. Of this, parthenium would be one of the most important one. It causes what is known as an airborne contact dermatitis, can be distinguished, is a separate topic by itself. And if Dinesh wants, one day I will come and talk on parthenium. So today I will not spend much time on this. But what we have to understand is that parthenium basically causes a contact dermatitis, and what we get is a photo-aggravated dermatitis. Although some people claim that it can cause photosensitivity. Our experiments tend to say that it is a photoaggravation than photoallergy or phototoxicity. But again, that is a small gray area. That is my concept of it. Then, of course, I already told you, it becomes dry, it comes in the air, and it can also cause pruritus ani, the Parthenium dermatitis. Even sun-covered areas can be involved. A dhobi will wash the cloth, he is not going to watch where he dries it. He will dry it over the Parthenium leaf, the undergarments, and people wear that undergarment and start scratching their perianal area. These are the dermatitis pattern, and one of it is photo pattern, other is the airborne pattern, and there can be combined mixed pattern. And over a period of time, this is also one of the causes that can go to chronic actinic dermatitis. Apart from Parthenium, there are other causes which can go to chronic actinic dermatitis. So this is the good old Parthenium. Thanks to Dr. Lonka. Who knows, maybe we might have remained ignorant even till today, thinking that it is some other unknown cause. But thanks to Dr. Lonka, as a private practitioner, he has shown the power of a private practitioner, what he can do. And myself and Dr. Lakshmi have been, in fact, even now I cannot walk past a Parthenium without admiring it, because it has defeated us all the way till now. We have not found an answer. But what we did find was Parthenium dermatitis can be because of all three, type 1, type 2, and also type 4 dermatitis. Sorry, type 3 and type 4 dermatitis. In other words, type 1, it can cause immediate, and type 1, it can cause delayed, that is the late phase reaction. Like if you do a prick test with Parthenium, you can get an immediate one, and after 24 hours, you can get induration over there. And then if you do a patch test, after 48 hours, we can get. If you do a patch test, Parthenium is one of the few conditions where if you feel with the fingers, you will feel an induration. That means there is an allergic contact dermatitis on the top and a late phase reaction below, which is what you are feeling with your fingers. So we reported this, and then we saw that many of the cases cannot tolerate sunlight. As you know, photosensitivity, photoallergy is mostly because of UVA, not because of UVB. Whereas in case of Parthenium, when we did a minimal erythema dose testing, we found it very significantly lowered to UVB and to some extent to UVA. In other words, it is a non-specific sensitivity, which is a photoaggravation. Even when we do patch testing, we get positive on both sides. The photo patch test site may show more severe reaction, but that is because of the photoaggravation of the patch tested site. Very rarely will you get the allergic test contact dermatitis negative and the photo patch test for Parthenium positive. That usually does not occur. Both will remain positive, and so it is allergic. Then we come to the polymorphic light eruption. As we say, polymorphic, that means different morphology. But monomorphic in a given individual. But in a same individual, at different time, it can have different morphology. Like in the month of June, it can have one morphology. In July or sometime, if it goes and comes again. Or in this year, it might have one morphology, another morphology next year. Or in the same person, there can be different morphology at different sites. So it is not that it is a unimorphic or monomorphic all the way, it can vary. As we said, it is idiopathic. That means we do not know the cause, but there is definitely a delayed hypersensitivity involved over here. The reason being, after exposure, there is a time lapse before which we get this. We know that in case of delayed, there is always a time lapse. The memory cells have to come and then play their role, and that happens over here. But also we have some type of polymorphic light eruption which can occur within 10 to 15 minutes or 30 minutes of exposure. So there can be early one, and sometimes it can confuse us with solar urticaria. These are the clinical features. What happens? It occurs during the early part of summer, and as the summer progresses, a person is likely to improve. That is, hardening occurs with this. Itching is the main symptom, very common in children. I personally believe that atopy plays a very important role. As we discussed, various morphology, urticarial can be there, vesicular can be there, even erythema multiforme like lesions can be there and has to be differentiated. This can be in the forearm where we get monomorphic lichenification, lichenoid type of PLE. In the Indian skin, we have a variant of this type of dermatitis, which will occur like lichen-nitidus, small. The biopsy will show the features of dermatitis, but clinically it will look like lichen-nitidus. It is somewhat asymptomatic as compared to other type of polymorphic light eruptions and tend to last much longer, but eventually it does go off. Another thing that can happen is, like when we are sensitizing someone with DNCB or SADB or any cyproterone, whatever we do that, when we are sensitizing a person, initially we use a higher dose. And then to elicit or maintain sensitivity, we use a lower dose as an alopecia areata. Likewise, the sensitivity is more likely to happen when there is an increased amount of exposure. A person goes for a holiday, he goes to Kottayam or he goes to Trivandrum, goes to the lovely beach and exposes a lot to sunlight. He gets sensitized. Or he goes to Ooty and gets sensitized. Or he rides a camel in Rajasthan without proper protection and he gets sensitized. And then he comes back into the land, back into here. And here he goes out for 5 minutes, he will elicit. Or a lady goes to hang the cloth, they will get. So sensitization had occurred when intense exposure was there, and maintenance by the smaller amount of exposure is what happens. So, but thing is, there is a very funny thing. Sunlight can reduce the immunity of the person. When immunity of the person decreases, the chances of developing malignancy becomes more because immunosurveillance becomes less because of the sunlight due to numerous mode of action. However, this ability to suppress sensitization is less marked in polymorphic light eruption. In other words, a person with polymorphic light eruption can be sensitized even when he is exposed to sunlight because the ability of the sunlight to reduce the immunity is less. And this provides him a certain amount of immunity against skin cancer. So what I tell all the people is, or even for individuals, even for a useless guy like me, you may find some positive quality. So even for a disease, you can find some positive quality. For a person with atopic, you can tell the mother, oh, atopic children are very intelligent. They will walk very fast. They will talk very fast. The child is suffering. The child is scratching. The mother is not sleeping. But this praise will make them happy. In case of PRURIGO, due to insect bite, we tell that this is a good immunity that is working, which is protecting. So they feel happy that we have told them something good is happening even when they are suffering. Likewise, for a patient of polymorphic light eruption, we can tell, okay, you are suffering now, but the chances of getting skin cancer is less. Usually we don't develop, but then it makes him happy. The next is hydrova vacciniforme. This occurs as a papular lesions over there, which can umbilicate, which can cause, can have umbilication on the top, will be painful, will be severely pruritic, and can heal with scarring. This I have seen till now about only 2 or 3 cases, relatively rare, but you have to be aware of it to catch the rare one. So this is what happens. There is intense burning, stinging, crusting over there, and then pockmark-like things occur on the face. Actinic prurigo is relatively more common. We do see it. It is possibly a variant of polymorphic light eruption. It occurs in children more than adults. Often there might be an atopic background in this. Boys get more than the girls. That is possibly because of the hairstyle. They cut off the hair, ears, pinna are exposed, and pinna is one of the sites that is commonly associated in actinic prurigo. Or the conscripts, the Jews who were in the prison, in the concentration camp, their head will be shaved off. Or the persons who are forced to join the army, their head will be shaved off. So ears are likely to get, so the conscripts are likely to get over the ears and other part. Whereas in case of girls who have longer hair, it protects the ears. It can also be associated with conjunctivitis, eye involvement, and lip scaling can be there. It is said that in some persons this does not improve with age, but what I have observed is in most cases it improves with age. So these are the clinical features. It occurs in the sun exposed site. We get papules which can be excoriated, crusted, it can be single, there can be lichenoid, there can be eczematous. It gradually fades off over a period of time. Next we come to solar urticaria. This is a physical type of urticaria. It can occur immediately following sun exposure and will also regress sometime after sun exposure. However, there are 2 types. One is the primary, which is an IgE mediated, and there is a secondary over there, which can be because of the drug or some disease or some photosensitizer in the body. Photosensitizer could be a drug like chlorpromazine, or it could be because of LE or because of cutaneous porphyria. So these persons can develop this sort of lesions on the skin and urticaria-like lesion and has to be differentiated. Can be done by various investigation. When we come to the investigation, I'll be telling about that. The clinical features, we get tingling, we get burning almost immediately after the person goes out. Wheals can be there. It is very incapacitating. It can be very disturbing to the person. And we had conducted a study when John James Ferguson from Framebell unit of Nine Wells Hospital, Dundee came over. We had a solar simulator installed in Manipal with which we did a lot of studies we did with that for finding out the MED and all. We did that study. And we also did a study on urticaria where we were able to suppress the urticaria by finding the minimal urticarial dose. We have a minimal erythema dose, we have a minimal urticarial dose. That amount of sunlight, be it the UVA, UVB, visible light, which can induce urticaria, is the minimal urticarial dose. So we induce the minimal urticarial dose, then give the antihistamine and see whether higher doses are required or we can stop. And by that we found that the H1, H2 antihistamines were effective. But here again, in some cases, antihistamines may not be effective because multiple other factors like leukotrienes, platelet activating factors may come. In those, we may require other drugs to these patients. So this is the minimal urticarial dose which we get, which we tested with solar simulator. We can test for the whole spectrum. Whole spectrum is, it will have UVB, it will have UVA, it will have visible light. That means from the xenon arc, the light as it comes through after removing the infrared is the whole spectrum. And then we put a glass filter, we can cut off the UVB, so it is the whole spectrum minus UVB. So if the whole spectrum develops and the whole spectrum minus UVB doesn't develop, that means they are not to UVA, that is to UVB. So by doing that, we can find out what is the cause for urticaria, action spectrum for urticaria, we can find out. Next, I am going to the chronic actinic dermatitis. This again is possibly a delayed type of reaction, very much like what we saw in case of PARTHENIUM, but it has been known by various other conditions. Persistent light, actinic reticuloid, photosensitive, salicylyl anilides have been caused. Even chromium can cause, dust can cause, various factors can cause. Some cases will look classically like PARTHENIUM, and you think that it is PARTHENIUM, and when we do patch test, we will find that it comes negative. Which is why I always say, even when you are 100% sure, there is a very strong chance that you are wrong. We investigate not to prove ourselves, but to prove ourselves wrong. Till now, in my whole this thing, in about 10 to 12 cases where I strongly suspected PARTHENIUM to be the cause of chronic actinic dermatitis, I found that patch test to PARTHENIUM prick test was negative. Not that I could find out what is the cause, but I do know that it is not because of PARTHENIUM. Then we have to differentiate between phototoxic and photoallergy. In contact dermatitis, we have irritant contact dermatitis, we have allergic contact dermatitis. Likewise, here we have phototoxic and photoallergic. Phototoxic is like an irritant contact dermatitis, where almost all who are exposed are likely to develop the dermatitis. Whereas in photoallergic, if 100 is exposed, not even one may develop, or 1 or 2 may develop the allergic contact dermatitis. If we give the psoralen, almost everybody will develop erythema when you expose them to UVA. Whereas drosopholvine sensitivity, very few will develop. That is photoallergic and this is phototoxic. And the difference also clinically, this is a various mechanism. I will not go too much into that because that itself will take. So phototoxic, photoallergy, direct tissue injury is there in phototoxic. It is mostly, both are mainly because of UVA, UVB plays. And like irritant, there is erythema, burning, edema, whereas that is more eczematous. Phototoxic, like irritant, will mostly over the exposed areas. Photoallergic over the other areas also. Borders will not be well defined, and we can get spongiotic dermatitis over here, and here we can get epidermal necrolysis. So the various substances which can cause phototoxicity, tar can cause, psoralens can cause. These are the various drugs which can cause both. Likewise here, it is relatively rare. But then having said that, distinguishing between these two can be difficult and sometimes challenging between these two. This is a case of photoallergic contact dermatitis to a drug which we recently saw. Next, I am going to some of the conditions which we see, xeroderma pigmentosum. I am not going to go into the depth of that. We all know that it starts right from childhood, difficult life for these people. Pellagra is another condition which we have to find. History of alcoholism becomes important, or vegetarians, or people with food faddism. can develop this. They will have all sort of necklace, gauntlet, and all those sort of things. Diarrhea. Often we don't get diarrhea and all that. What we usually see will be photosensitive dermatitis, and then giving them the vitamins that completely disappears. Lupus erythematosus again can cause, there will be photosensitivity associated more to UVB than to UVA in this. In fact, it is a photo aggravation because of UVB, and we have to protect these persons from light, damage to sunlight. The clinical features are there. You all know about DLE. I will not be going into the depth of that. And this is the case of xeroderma pigmentosum, where we did camouflage for this person, and we used it. And we found that the camouflage itself, when we did a MED for that, you apply it well, has got up to 15 SPF. So the camouflage itself is a protection factor. And the good thing about the camouflage is it has got a good substantivity. That means it is not easily washed away. It takes time, but a person can apply it on the face. And so we did this. And then if you want to apply the sunscreen, one can apply it above the camouflage. That will be an additional protection for these people. So SLE, the features, again, not going over here. Actinic lichen planus can occur on the exposed areas, and I will show you a picture. You can see on the nose, a pigmented one with a raised border, somewhat like porokeratosis. It might be confused, but if you look carefully, you can find out the actinic. There is minimal pruritus. It won't be very severe in these cases. Cocaine syndrome, again, is a autosomal recessive because of fibroblast defect. There can be pre-malignant. Again, I'm not going to go into the depth of that, mostly because I cannot remember. If I see a case, I take a book and read. Blooms, again, same thing. Clinical features, Rothman-Thompson. These are the various conditions which one should look for when we are having the conditions. Porphyrias, we know that in porphyria photosensitivity occurs. Porphyria cutanea tarda is very common abroad. It's relatively less common over here. But erythropoietic porphyria and erythropoietic protoporphyria can occur over here. And erythropoietic protoporphyria can have very clear urticaria lesions which will look very much like solar urticaria. So here if you do an immunofluorescence, the RBC will fluoresce, and right in front of your eye, the fluorescence will disappear. Whereas in erythropoietic porphyria, when we see, the fluorescence will persist. You will keep on seeing the stars will not fade away. Erythropoietic protoporphyria, the stars will fade in front of your eyes. So this is the porphyria. Then of course, Hartnup disease will have a pellagra-like picture. We can investigate. How do you do? Investigations in case of photodermatology is little challenging and requires a lot of dedication, requires a separate unit, but certain things can be done. Like I will tell you what can be done in this. The best one to test is the most difficult one is known as the irradiation monochromatin. With this, what we can do is we have the prism type or we have the grating type. With this, we can split the rays into different wavelengths and we can expose a person to different wavelengths and then find out plus minus 5, and then we can find out to exact which wavelength this person is sensitive to. It is difficult to maintain, and only in places where they are doing research, this is usually maintained. This is the monochromatin. This is the grating type of monochromatin. I have seen this in Dundee and in St. Thomas Hospital. Then we can do photo provocation, wherein we can expose a person to the light and see how it works. Like we have a Honle's lamp, we can expose a person to the whole spectrum minus UVB by putting a glass, and we expose the person daily for about 4 or 5 days till the lesions develop. Then what we use is a solar simulator. Solar simulator is a cheaper and relatively more easy to manage than monochromatin. Here also the source is the xenon arc lamp. The spectrum matches that of the skin. So the sunlight-like light is emitted. It comes out through a small aperture. When the light comes out through a small aperture, all the light, infrared light, visible light, all the light, visible light will come through it. So we can put an infrared filter in which one this year we put copper sulfate in with sulfuric acid that will absorb away the infrared. Infrared is responsible for the heat. So minus infrared will come out through the solar simulator. And when we expose a person to that light, that is to the entire light. Then we put a filter, cut off the UVB. Then we put another filter and cut off part of the UVA. So by that, by using various filters, we can give different amount of dosages of different wavelengths of light and to find out which wavelength is responsible for the dermatitis. This is the solar simulator. You can see the solar simulator. We can give multiple type of rays at the same time. And then of course is the provocation I told you, which we can do with the onless lamp or even with the sunlight a person can expose, and we can find out this. So sunlight, anybody. So ask a person, if they say they're developing when they go out in the sunlight, ask him to go walk out in the sunlight and come, or make him sit by the window and then see. It doesn't take much money. It only wants. Then we can find out the minimal erythema dose. In many cases of photosensitivity, we'll find, especially in case of PARTHENIUM, dermatitis and all, the minimal erythema dose is lowered. So that we can find out by exposing the person to ultraviolet B, to narrowband. What we do is, there is a, I'll show you the picture. This is the cloth and this is myself standing over there. It's a cloth, a template with multiple holes over there. So what we do is, first we'll give 5 millijoules with all the apertures open. That means all the apertures will get 5 millijoules. Then we'll close one and give 5 millijoules more. That means the first one has stopped at 5, rest all will get 10. Then we close the third one, then another 5. That way, increment 5, 5, 5, 5. Then after 24 hours in case of UVB, after 48 hours in case of UVA, we can go and look for the erythema to find out if a person has developed minimal erythema dose or minimal phototoxic. With UVA, we talk of phototoxic dose. With UVB, we talk of minimal erythema dose. Minimal erythema dose is the minimum amount of light that is required to cause an erythema. Likewise, we can do a photo patch test. Photo patch test is using those allergens which can cause phototoxicity or photoallergy. So by photo patch testing, especially in the Indian skin, it is very difficult to distinguish between phototoxicity and photoallergy because we use 10 joules or 15 joules. In the white skin, they can use 2 joules and elicit the sensitivity. That is not possible because we use high dose. We are eliciting both. We don't know which by this, but we can identify the photosensitizer by this. We apply the photosensitizer in duplicate over the back. After 24 hours, remove both. Examine both for allergic contact dermatitis and then cover one with a black cloth and a black paper. Then expose one side to ultraviolet A, 10 or 14 depending on the center, and then cover both so that additional exposure does not occur. And we can call the patient after 24 or 48 hours depending on the institution's guidelines, and then we look, and then by this, if both develop, it is allergic contact dermatitis. If only at 24 hours itself we will know. If the covered one is negative and the exposed one is positive, then it is photoallergy or phototoxicity. If both are positive and the exposed site is more positive, then most probably it is photoaggravation of the patch test. So this is what we do. We expose the person after light and we check. We use the chemotechnic series, Scandinavian series. That is not available, but you can make your own. The best thing is to use the various sunscreen because most often sunscreens are the cause. So take different sunscreens and do the patch test to find out. Then we come to the protection. How do you treat this person with the photodermatitis? One is the behavior, which is very bad for most of us, but then good behavior is required. Clothing is required. Clothing is by far one of the best ways to. And then third, and at the bottom comes the sunscreen. Avoid the peak hours, seek shade, which naturally a person with xeroderma pigmentosum, he will show us the way as to which time should be avoided. I tell persons that they should protect themselves from the time light is put off till the time light is put on. So when are you going to put off the light? When sunlight is bright enough. When are you going to put on the light? When sunlight is not providing adequate light. So from that time till this time, a person has to protect himself from the sunlight with clothing. Thicker cloth, tightly woven cloth offer better protection. Thinness, more than the thickness, it is the weave that is more important. And we should cover as much as possible. You can see the weave. Satish has made this, I don't know this thing. But you can see the weave with this picture itself tells the important thing. Cotton offers protection, but only after 2 or 3 washes. The fibers will permit light when new one is worn. White will offer protection, but will on getting wet, it will permit more light. So these are the ones for clothing. Thickly woven clothing will have washing will increase the UPF, especially in case of cotton. Others it does not. Any fabric that tends to stretch, if you stretch, the holes will become more. So the SPF will UPF will go down, and then the chemical treatment. If you bleach and all, then the cloth can become thick. The dyes may go off. The fabric may become thick, and the protection reduces. Then comes the sunscreen, and the question is which sunscreen, how much sunscreen. We require 2.5 to 3 ml. So we did this study wherein we applied a string around the face of a person, then converted that string into a circle, and then using the formula pi r square, we calculated the area of the face, and then we found out how much amount of sunscreen is required. The same thing we did, the string we applied for the forearm to find out, and we found that we require about 2.75 to 3 ml for the sunscreen. So this is how we found out sunscreen application, not less, not more, and that face of the person is Dr. Karthik Prabhu, one of our students and now a very successful private practitioner and very active in IMA. This is one way to protect yourself, and also people are not going to post comments on this thing. Hats play a very important role. The larger the brim, better the protection. But then if you are an actor, you can get away movie, you can wear with singing this communist song, Mera Juta Hai Japani Patloon Englistani, the hat will offer protection. But this is what you people can offer to us from Rajasthan. Here is a turban which is large. Here is a turban where the clothes are wound round. It traps a lot of air and offers protection. So this is the one that would be the ideal for protection. This possibly is the reason why in Rajasthan people wear this sort of turban. Of course, this is not a reason for growing the mustache. Then, of course, one way to find out if a person is sensitive to UVA or UVB is if a person has polymorphic light eruption, then you can ask him to stand behind the glass. First, stand with the windows open, and then one part of it exposed. See if he develops the light eruption. Then, with behind the window, if behind the window he stands, behind the glass he stands and does not develop, that means UVB is the cause. Whereas with the whole one he develops, if a person develops directly on exposure, then we do not know whether it is UVA or UVB. And then if he stands behind the window, glass window, and then the light comes, UVB is cut off, and if he develops, that means he is allergic to UVA, and if he does not develop, it is because of UVB. For this, you don't require any great instruments or anything. It can be done in your OP itself. Then, of course, sunscreens, we have the various sunscreen, organic. This is not a talk on sunscreen, so I will not be going into the depth of that. That's a topic by itself. But what it does is, it gets excited, it absorbs a photon, gets excited, liberates it as a heat energy. Like Einstein told us that one form of energy can become another form of energy and does not get destroyed. And here it liberates heat, which is why when a person applies sunscreen, there is more amount of sweating. There is a sense of heat in the sunscreen when you have the discomfort we get because of the sunscreen. And of course, if the person is sensitive to the chemical, it can cause both phototoxicity and photoallergic reaction. It actually, basically, the physical sunscreen, it acts by scattering away the light in different directions. These are the physical sunscreens. It scatters the light, reflects the light in different direction. We can measure the protection by sun protective factor, mostly for ultraviolet B. That means a person exposed to ultraviolet B, whole band, whole spectrum of ultraviolet B, find out the minimal erythema dose, apply sunscreen, and then find out the minimal erythema dose. The ratio will tell them. Then make him take bath in the swimming pool and then try to find out. That will tell you whether it is washproof or not. Washproofing is substantivity. So SPF, this means 30 means a person can expose to 10 minutes, but if he applies the sunscreen, he can expose for 300 minutes. But this is not true. It is like Hero Honda telling for 1 liters under ideal conditions, it will go for 80 kilometers. This doesn't happen in practice. So for UVA, we use the pigment darkening the tanning effect, which we see instead of the erythema, which cannot be really elicited. Then we apply the sunscreen and do the PPD. Then there are other ratings like boot rating, star rating for UVA. So these are the protective factors for sunscreen. Critical wavelength, which is defined as the wavelength below which 90% of the sunscreen's UV absorption occurs as measured between 290 to 400. That means for each sunscreen, there is a critical wavelength and it should absorb that much amount of sunlight. So sunscreen should have this ideal quality. There is no ideal person, there is no ideal sunscreen. In fact, most of it falls short of ideal. Some are very, very expensive, maybe slightly better, but not really. The cost doesn't justify it. Sunscreens are difficult to use and it should be used 20 to 30 minutes before. It should be applied as an even layer, not as an irregular layer, and at least twice, but if possible more frequently. It is like, petrol. When you expose more to light, more sunscreen gets exhausted. Like when you're climbing the hill with a petrol-driven car, you consume more petrol. So when you go out in the sunlight, sunscreen also is more consumed over there because it gets inactivated. So you will have to apply more sunscreen when you're indoors, you can apply less amount of sunscreen. So this is how you apply teaspoon rule, fingertip rule, crown method rule. The teaspoon rule, which is used more than half, that comes to 2.5 to 2.34 ml. This thing of a half a teaspoon for the face, neck, arm area. This is the teaspoon rule, which is easily available. More if you are going out in this thing. Then the fingertip rule, if it is in a tube form. Anatomical side, different amount of sunscreen that is required. Crown lid, have your beard, don't throw away the cap. Use it for applying the sunscreen and then lie down in the sunlight. Have it and protect yourself too. This is the crown lid method. Talcum powder, does it offer? In the south, talcum powder is very, very popular. People will apply the powder. So myself and Sridhar, we thought, will it offer protection? We did a sun protective factor study with that and found that yes, it does, but it is very, very less, between 2 to 2.5. We have to increase the zinc oxide content for protection, but then cosmetically it may not be that acceptable. Can we apply a talcum powder on a sunscreen so that the oiliness is not there? Possibly it will reduce the effectiveness of the sunscreen by absorbing or adsorbing the sunscreen and permitting the light to go through, but this has to be confirmed by a study. So sunscreen is essential for people in the light skin. Once when they said sunscreen is required from womb to tomb, one Australian said, Dr. J.S. Pasricha told that you people Australians are the wrong people in the wrong place. Aborigines should have been there. You are not supposed to be there, so you cannot tolerate the sunlight. Those people are well protected, don't need it. In Indian skin also is reasonably well protected. Sunscreen is essential for the pigmented skin. Provided they have got some diseases like discoid lupus erythematosus, xeroderma pigmentosum, then it is absolutely essential. Or if a person is undergoing cosmetic therapy like chemical peels or dermabrasion or microdermabrasion, here what we do is we remove the stratum corneum. And what is offering us protection? Everything is there in the stratum corneum. We are getting rid of the stratum corneum. We are increasing the transepidermal water loss because barrier is gone for a 6. And then we apply the sunscreen, thereby increasing the possibility of allergic contact dermatitis to the sunscreen. So we have to be careful. Over a period of time, there is a possibility that allergy, phototoxicity, photoallergy to sunscreen is likely to increase because of the increased use of cosmetic therapy. Sunscreens are again expensive, difficult to apply. As recommended, you have to apply it 3 times, 4 times, and not so easily done. So in India, photodermatosis is quite common, the ones which I have discussed. Identification is important. We have to identify it. Protection is important for those people. Not all people with polymorphic light eruption will require a sunscreen. And also, it is always better to encourage a person for clothing, because in the bargain you get a shirt. Here you only get the sunscreen which we use up. So you tell them, instead of spending 280 rupees or 320 rupees on the sunscreen to apply all over the body, apply it only on the face and dorsum of the hand and protect your forearm with your clothing, they will nod their head, they will say yes. Next time again, you will find that they will come with cut sleeve, and you ask what happened. He says, I am I am not habituated to that. So people are not willing to change. So, but still, we have to tell them to use it, and that is a better way. Of course, as I always say, that one way to reduce polymorphic light eruption is to go exposed to the sunlight regularly between, say, in the morning, say 6:37 or 4:35. What happens to the ladies? They never expose. If they expose regularly, then that is the reason why people who don't go out, people will tell you that I am not going out at all. So why should I get sunlight allergy? That is the reason. Because you are not going out, your tolerance is not there. If you go out for a walk in this mild amount of sunlight, it is possible that you may not develop the light eruption. And of course, during this namaskar may also help, but do it little late if you are going to do that. So thank you very much, Dinesh, Dr. Agrawal sir, and all others for giving me this opportunity. Thank you very, very much. I am indeed honored. Thank you.
Thank you, thank you, thank you, Dr. Sriniwas. It was indeed a very nice lecture. And Dr. Lalit, can you see the chat box? Let me first unmute everyone so that please, people can unmute themselves. And Dr. Maniyar sir.
Yes, sir.
Yes, sir.
Be a minute.
Yes, please.
Hello.
Yes.
I think it was a very nice lecture.
Excellent.
Excellent lecture.
Any questions? It was so, because the chat box is full of. Thank you, and a very, very nice lecture, and all these things were so self-explanatory.
Thanks, Dinesh.
Thank you very much, sir.
Thanks to you, sir.
Thank you very much, sir.
Thank you very much, Sriniwas. It was indeed a very nice love. I have not heard such an excellent lecture on photodermatosis.
Everything has been covered.
Photobiology is a topic close to my heart also, and I have not heard such good lecture. Thank you very much.
Thanks, sir.
I
Thank
thank
you.
my students who have been with me and who have encouraged me and cooperated with me and helped me conduct the studies. So I dedicate my talk to my students for
Great.
understanding this. They have helped me understand.
All right.
Thank you.
Thank you very much. And this is Arun Joshi from Kuwait telling that this is a master class in photodermatosis, great informative from basics to clinical application, excellent analogies and nuggets. And rest everyone is appreciative, all appreciative charts. So thank you very much, and I say good night to all, and see you next week.
Thank you.
Bye.